But without further ado, we're going to introduce our next speaker. Dr. Faye Hant is a professor in rheumatology and immunology in the College of Medicine at MUSC. She's the director of the Rheumatology Fellows Program, as Dr. Silver pointed out, and that's such an important, exciting program because it helps, we're investing in the future, investing in the likelihood that we're going to have qualified people to help do the research and take care of us, because every day we're getting a little bit older. And I'm just delighted to have Dr. Hant here. She is my doctor, so I'm just delighted she's here. But we're all kind of clipping down that road, so I want some young people in the chute behind us getting ready, because we're all going to need that. So thank you so much, Dr. Hant, for joining with us and providing us with this update. Remember, everybody, put your questions in the chat box, and that'll help us know what you're thinking and what you're curious about or what you're unsure about. So welcome, Dr. Hant. Please take it away.
Awesome, Karen. Thank you so much. And thanks for this opportunity to talk with everyone about COVID-19. And obviously, we've all been through the last 2 years together. So this is a very much evolving area. I kind of look at it as sort of the Wild West, if you will. Every day as clinicians, we're being given new information and ways to take care of patients. And so I'm going to be sharing with you a lot of information. Certainly happy to field questions at the end and share those as well with my colleagues here, Dr. Silver and Dr. Baker-Frost. So just a few caveats. COVID-19 is an emerging, rapidly evolving situation. Recommendations are not intended to replace clinical judgment. And so a lot of what I'm going to tell you are sort of guides, if you will, but your best and biggest resource is going to be your own doctor and your own clinician, because every patient is different. Their disease manifestation may be different. They may be on certain medicines. They may have certain organ involvement. They may have other comorbidities like being diabetic or having high blood pressure or other things that may make them higher risk if they were to get COVID. Modifications to treatment plans are also highly disease, patient, geographic, time specific, and really has to be individualized. So your own unique situation and talking with your own doctor is the biggest important thing in a shared decision-making process. Guidelines and recommendations, again, are rapidly evolving as evidence and data become available. And we're, again, constantly getting updates and recommendations and changes, some of which you'll see when we go through this, and I'll try to point them out. So, as you know, we've been inundated with COVID for 2 years now. You can see here that with the Omicron variant around right after Christmas, we had a tremendous spike. It's kind of hidden behind here. You can see as of 2 days ago, we had 245 new cases on that day. And over the last 14 days, so from January 28th to February 10th, about almost 7,000 total cases just in Charleston County. So we're seeing lots of patients, and having just been on the inpatient service, we've got a lot of patients in the hospital with COVID. And you can imagine the clinical and organizational challenges in the setting of a pandemic. So as an example, this is a nice article that has highlighted the impact of COVID-19 on rare and complex connective tissue diseases. And you can see some of the challenges, limitations on the diagnostic process and routine monitoring of patients with connective tissue diseases like scleroderma, managing infection risks in patients that you need to start on a new immunosuppressive medicine, manage infection risk in patients already taking immunosuppressive therapies, limited access for some drugs. So at the beginning of the pandemic, perhaps you might have been on Plaquenil and there were issues getting that because it had been touted as a potential treatment, which we know now is not the case. Akin to that are patients who might be on Actemra, which is now being used to treat COVID. And so having to switch, as an example, from infusions to injections and trying to make sure our patients have the medicines they need. Also, the difficulty in face-to-face interactions, having to do televisits with your provider. And then the potential for relapse if we had to suspend your therapy, as an example. And then, organizational challenges, telemedicine conflicts, or, technology not working, interrupted care, patients wanting more information, and prioritizing, the services that we can have has all been very impactful on the healthcare system as a whole. And so we as rheumatologists and you as our patients really need to discuss your vaccine status and engage in shared decision-making. We know that patients with autoimmune rheumatic conditions, including scleroderma, are at a higher risk for hospitalization with COVID-19 and are potentially will have worse outcomes compared to the general population. Unless you have a known allergy to a component of the vaccine, there are really no contraindications to getting it. And we do know, though, that the expected response to the vaccine for many patients with autoimmune conditions on systemic therapies is likely blunted in its magnitude and duration compared with the general population. So patients on things like Cellcept, rituximab, are not going to mount the same immune response to the vaccine. There is a theoretical risk for flare of autoimmune condition or disease worsening after a vaccine. However, the benefits outweigh the potential risk for new onset autoimmunity and flare. I know in my own practice, and I would welcome my colleagues' input as well, I have not seen any flares specific to scleroderma after vaccination. So just to sort of recap how these vaccines work, the vaccine spurs healthy cells to produce viral proteins and stimulates a potent immune response. So remember that the coronavirus, which causes COVID, has these crown-like spikes on the surface called spike proteins, and these are ideal targets to vaccines. So scientists have generated this mRNA sequence that codes for the virus spike protein. It's encapsulated in a lipid coating, which allows it to be protected. And then you get the injection of the vaccine. This RNA that's in this lipid coating is a blueprint and tells your body how to make the spike protein. Once it arrives, the cells read the information in the mRNA and sequence to provide millions of copies of the spike protein. And that allows your body to then spur the immune system to produce antibodies, so that when you are infected, or if you are later exposed to the true real virus, your body will recognize it and use these antibodies to fight it off. So a very important thing to know is that these mRNA vaccines cannot give you the virus that causes COVID-19. These vaccines do not use live virus and cannot cause infection with the virus. It also does not affect your DNA in any way. The mRNA does not go into the nucleus of the cell where your DNA genetic material is located, so it does not influence your genes or change your genetic makeup. And the mRNA and spike protein don't last long in the body. Our cells break it down and get rid of it over time. So these are safe and helpful and are recommended. So just to quote the CDC director, this Omicron variant has been spreading quickly and has the potential to impact all facets of our society. CDC's updated recommendations for isolation and quarantine balance what we know about the spread of the virus and protection provided by vaccination and boosters. These updates ensure patients can continue to safely live their daily lives. Prevention is the best option: getting vaccinated, getting boosted, wearing a mask in public indoor settings, especially in areas where there are substantial and high transmission rates, and getting a test before you gather to ensure you're not sick and will not create interactions with people that could get them sick. So just to discuss the newer recommended isolation and quarantine periods for the general population, We know that the majority of COVID transmission occurs early in the course of illness, usually 1 to 2 days prior to the onset of symptoms and 2 to 3 days after. So remember that isolation relates to your behavior after you have an infection. So the recommendations are to isolate for 5 days, followed by wearing a well-fitting mask, which will minimize the risk of spreading it to others. Remember that quarantine refers to the time following an exposure to the virus or close contact with someone known to have COVID, okay? And so there are recommendations that I'll go through in a minute, but we know that as the Omicron variant spreads, we know that data from South Africa and UK demonstrate that if you've had 2 doses of an mRNA vaccine, the efficacy or effectiveness rather is about 35%. If you've had a 3rd dose or booster, it restores that to up to 75%. We also know that vaccination decreases the risk of severe disease, hospitalization, and death from COVID, and vaccine is the best way to protect yourself. I would encourage everyone to know the cdc.gov/coronavirus as a tool. There are a lot of really good information there for patients to review if you have access to a computer. So if you test positive for COVID-19, you need to isolate, you need to stay home for 5 days. If you have no symptoms or your symptoms are resolving, you can leave your home, but continue to wear a mask around others for 5 additional days. If you have fever, you need to continue to stay home until that resolves. If you were exposed to someone with COVID-19 or were in close proximity to someone with COVID-19, you should quarantine. And these are differences between whether you've been boosted or not boosted. So if you've been boosted, you've completed the primary series of an mRNA vaccine or the primary series of a J&J vaccine. You need to wear a mask around others for 10 days, and you should test for the possibility of having COVID on day 5 if possible. And certainly if you develop symptoms, you should get a test and stay home. If you completed the primary series of an mRNA vaccine over 6 months ago and had not been boosted, or you completed the J&J dose over 2 months ago and are not boosted, or you are unvaccinated, you should stay home for 5 days and continue to wear a mask around others for an additional 5 days. If you can't quarantine, you must wear a mask for 10 days, and everyone you should test on day 5 if possible. And obviously, if you develop symptoms, you should get a test and stay home. So more recently, for moderately or severely immunocompromised people, the CDC has updated its guidelines regarding vaccination, okay? And so I'm gonna go through this with you to kind of review it. So people are considered to be moderately or severely immunocompromised if they have been receiving treatment for active cancer, an organ transplant, taking immunosuppression for that, those who have received a stem cell transplant within the last 2 years or are taking medicines to suppress the immune system related to that, those with a moderate or severe primary immunodeficiency, those with advanced or untreated HIV infection, and those who have active treatment with high-dose steroids or other drugs that suppress the immune system, which many of you might be on. And so you should talk with your doctor about whether getting an additional primary shot is appropriate. So I'm going to go through this with you. So it used to be that if you received your first 2 doses of an mRNA vaccine, you then got a 3rd vaccine, which was a booster, okay? Now the recommendations for those on immunosuppression is for folks to get the first 2 vaccines, a 3rd dose, 28 days after the 2nd shot or longer, and then 5 months after that to receive a 4th vaccine, which is now considered the booster, okay? And so you might ask, well, you know, what do I do if, and we can certainly talk about individual situations, but if you are on an immunosuppressive drug and you may think that you need a fourth vaccine. That fourth, you are probably right. You need to speak with your primary rheumatologist, and they can tell you when to go and get that fourth shot, which should be 5 months from the third one, okay? If you received the Johnson & Johnson vaccine, which is not the mRNA, which is not an mRNA vaccine, at this juncture, there is not additional information. You certainly can get the booster after 2 months, but we don't know additionally if you should get a third shot, if you will. We know that the Johnson & Johnson vaccine is probably not as effective as the mRNA vaccines. And so some providers are recommending if a patient has had a J&J vaccine to go on to get an mRNA vaccine, but that needs to be individualized with your provider. Another thing that's important when you're on immune suppression is the use and timing of the vaccine related to your medications. So many patients with scleroderma may have scleroderma and may be on some of these medicines for various reasons. Some patients with scleroderma may also have overlap syndromes. You may also have rheumatoid arthritis, or you may have lupus, and you may be on these other medicines as well. Please note that these recommendations have also changed and evolved. So we have our American College of Rheumatology, which is now in its 5th version of this guidance paper. And so some of these things may have changed since you last spoke with your doctor. And so if there is consideration and you do need that 4th booster, you should talk with your doctor to make sure you don't have to hold some of the medicines, or whether it's appropriate in your case, okay? So as an example, sort of focusing on patients with systemic sclerosis that may be on CellCept as an example for their interstitial lung disease, it's now recommended that the CellCept be held for 1 to 2 weeks as disease activity allows after each vaccine dose, okay? Because we know now that CellCept can blunt a patient's immune response to the vaccine, okay? So these are a list of various medicines. You may see one that you are on, and you can see here that we may have to hold that medicine for a week or 2, depending on the situation. If you have very active disease, or your clinician feels that holding the medication is not in your best interest, then they will be the one to decide that with you. If you take IVIG for skin disease, or Plaquenil for your joints, there is no need to modify or hold those medications. If you're on a B-cell depleting therapy like rituximab or another anti-CD20 agent, then you need to discuss the timing of vaccination with your provider. These medications as B-cell depleting drugs very much suppress the body's immune response to the vaccine. And so there are measures where we would try to time it 2 to 4 weeks before you are due for your next infusion, if possible. Okay, so I just want to make sure that everybody knows, looks at some of these medicines and discusses with their provider whether they need to hold any of their medicines. Okay. Now, moving on to some COVID-19 therapeutics. Okay, so if you were to get COVID or be exposed to COVID, there are monoclonal antibodies. We know that the region COV and the BAM-ETE are unlikely to retain activity against Omicron, but sotrovimab appears to retain activity based on cell culture data. So your provider, if you were to get exposed to COVID and get COVID, and you're within 10 days of that, your provider may want you to get an infusion of antibodies to help protect you against the COVID virus. So it's very important that you contact your provider should you test positive for COVID, That way they can decide whether you should receive that monoclonal antibody infusion. I have underlined and starred Evusheld. That is not a treatment once you have COVID. That is a pre-exposure prophylaxis, and I'm going to talk about it in a few slides as a separate entity. Okay, this is to try to prevent you from having a problem were you to be exposed to COVID. Remdesivir or Veklury is a antiviral agent approved for use in hospitalized patients. It can be used off-label for outpatient use, but it's a 3-day IV therapy, very difficult to set up, and something that could be considered. And then there are oral antiviral drugs, molnupiravir and Paxlovid. These are also antiviral antibodies that are, oral antiviral drugs. There are limited quantities. They require a prescription, and they are authorized under an emergency use authorization from the FDA. So these are not approved by the FDA. These are also not, we cannot give them to patients to have on hand in case they become sick or they test positive. And some of that has to do with side effects and other things, as well as their quantity. So I just want to mention these. And on the top here in orange is the Paxlovid, and in the purple here is the molnupiravir. Okay, Paxlovid is these are protease inhibitors, and they essentially impair the virus from replicating, and it can be used to treat mild to moderate COVID in patients 12 years and over who have tested positive and are at high risk for progression to severe disease. This shows you the dosing. If you have significant renal disease or kidney impairment, it is not recommended, and it has to be started within 5 days of symptom onset. That's one of the reasons you need to let your providers know when you have symptoms. This medication has very, very significant drug interactions because of how it is broken down. And there are many medications that we use, especially in patients with scleroderma, where this medication cannot be used. As an example, if you're on Bosentan, if you take tadalafil or sildenafil for your pulmonary artery hypertension, there are too many interactions. So your provider would know and would have a list of all the medicines that do not do well when interacting with Paxlovid. And so this may not be an option for many patients. The other agent here is used under the emergency use authorization for adults who are at high risk for severe disease and for whom alternate treatment options are not accessible or clinically appropriate. And you can see here these doses, 4 capsules twice a day for 5 days. No adjustment for kidney disease, again, needs to be started within 5 days of symptom onset, and cannot be used in pregnancy. When a clinician is faced with a patient who is immune suppressed, who is at risk for severe COVID, we are thinking about what are our options to give to the patient, whether it's an infusion of a monoclonal antibody, whether it's one of these oral COVID treatments, if appropriate. So numerous factors are going to affect the selection of the best treatment option for patients. So again, what is the clinical efficacy of the treatment option? What is the availability of the treatment option? As an example, from the previous slide, those 2 oral agents, there are only certain pharmacies within the state that even carry it, and there are very small numbers available. And so patients have to be categorized appropriately. What is the feasibility of giving someone an IV medication, as an example? What are the potential for significant drug interactions? And I alluded to the Paxlovid. The timing of illness. If you were to get COVID and you don't let your provider know until 10 days into it, you're not a candidate for several of the treatments that might be available to you. And then the regional prevalence of the various variants that we have. The variants, like as a VOC, as a variants of concern, various variants of interest. So there are 4 different levels that these variants occur and can affect the treatments and whether they're going to work. We know that the risk for progression is very much higher in those who are not vaccinated or boosted, and those who are vaccinated and not expected to mount an adequate immune response to the vaccine. So again, patients on immune suppression who may just not mount the response. So despite doing everything the right way, you got your vaccine, you got the booster, sometimes the medicines you're on just don't allow your body to mount the response, and we want to protect those patients. When there are logistical or supply constraints that make it impossible to offer the therapy, patient triage might be necessary. For some of the treatments, and I'm going to allude to the Evusheld in a minute, there are actually panels and committees that are risk stratifying groups based on their age, their vaccine status, their immune status, and their risk factors to try and deem who would be best for the various therapies. So that brings me to Evusheld. I know that Susan had sent me that some folks had some questions about Evusheld, and this is a medication. It is 2 monoclonal antibodies, tixagevimab, co-packaged with silgavimab. And again, it's investigational and not approved. So what it means by being investigational, that it's still being studied, okay? But the FDA did authorize it for emergency use. And so it's very important to realize that this is a pre-exposure prophylaxis to prevent COVID-19 in various patients. So people should not currently be infected with COVID and have had no close contact with someone who is infected. And they have to have a moderate to severe immune compromise due to a medical condition, or have to have received immunosuppressive medications or treatment and may not mount that adequate immune response. So as an example, if you're on Rituxan or rituximab or high-dose steroids for whatever reason. Or if you're someone who the vaccine has either, it is not recommended. So if you have severe anaphylaxis to a component in the vaccine and were unable to take the vaccine for that purpose. So Evusheld comes in a dose of 2 separate intramuscular injections, usually given in the buttock. After an initial dose, you may need to continue getting additional dosing for ongoing protection, and that might be administered every 6 months. Because this is still investigational, we don't know all of the side effects. If we read sort of the guiding principles and our provider information, there is the possibility for allergic reaction. There were some noted cardiac events compared to patients who received placebo, and then pain, bruising, and swelling at the injection site. Remember that this does not replace vaccination. Vaccination is key. It's not authorized for post-exposure. So if you've already been exposed it defeats the purpose of the use of this, and it's not used to treat an active COVID infection. Okay, so essentially these two monoclonal antibodies act to, I don't know if you can you see this? Essentially here, the spike protein, they come in and they bind the spike protein, and you can see here where it is attached, and it does not allow for binding to the host cell, and so it gets inhibited, and that's how that's working. So it's very important that you protect yourself and others. So getting vaccinated, again, if you are eligible for that 4th booster, it's important that you talk to your provider to find out if you are, and they will guide you as to how and if you should hold your medication after that 4th booster. You should be wearing a mask. You should be staying 6 feet away from others and just protecting yourself as well as others, avoiding poorly ventilated spaces and crowds, testing to prevent spread to others, similar to how we went through the quarantine and isolation update. So getting tested if you've been exposed 5 days after exposure. Wash your hands often. Sneeze and cough into your arm, clean and disinfect, monitor your daily health, and then follow the recommendations for quarantine isolation and take precautions when you travel. A lot of patients and people were just, getting tired of being at home, not seeing loved ones. And so talk with your doctor if you're planning to travel, and they can also make other recommendations to you on an individualized basis. I wanted to sort of close the talk with just the importance of mental health and well-being. This is a very nice chart from the Association of Rheumatology Professionals, where it kind of breaks things down. There's so much out there, so much misinformation regarding COVID, politicalization of COVID, et cetera, et cetera. I think it's very important to look at resources. So just some resources here for positive news outlets, relaxation, meditation, tools to boost your happiness. So these are various podcasts. And then uplifting activities, enriching activities, other mental health resources, and then work and family tips. So these might be some resources for you to use and enjoy. And I just want to thank everyone, patients and families, for again entrusting your care to us. The National Scleroderma Foundation, Susan, Karen, and Francis, and then my colleagues and the fellows at MUSC. And I'm sure that this talk will lead to many questions, and so happy to take those. And I appreciate your time.
Thank you so much, Dr. Hant. That was a ton of information, and I feel like you answered many questions for folks, but we do have 4 questions, I think, from the chat box that I just want to make sure I touch on, and there might be some more percolating in, but I'll make sure I touch these. First, I think you really did answer, but maybe just one more caveat. Harriet asked about, can we get a second booster now? So you really addressed that, but it particularly related to folks who were immunocompromised. If not immunocompromised, should you just talk with your healthcare provider about whether it's a right choice for you to get that 4th shot?
Correct. So if you are not immune compromised, let's say you are somebody and you are just on Plaquenil, or you're not on any immune suppression, you should have that discussion with your provider. And some of that may be related to your autoimmune condition. So if you have significant some lung disease, you have a high body mass index, you have other risk factors, you might be considered, not immune suppressed from medication, but immune compromised for other reasons, or have higher risk factors. So definitely talk to your provider.
Yeah, so it could be an option, but that is, all those factors have to be considered. So another similar question was, are patients with diffuse scleroderma more likely to have a really bad outcome if they get infected, even if they're vaccinated and they're not on immunosuppressive drugs? So that's more like an epidemiological question. Are we at more risk for having a bad outcome just because we have scleroderma, regardless of immune suppressing drugs?
Yeah, I kind of alluded to it on the third slide. Like, I think the data is, we don't have all that data yet, but if you have an underlying autoimmune condition, you are at higher risk to have a more severe outcome and or be hospitalized.
I guess especially depending on what body systems are affected by your disease, so what might be vulnerable. So another question was, so there's two more. Another one was, which provider would be the best for us to talk to about making that decision? I think that might be hard to ask, right? But they're asking, should we go to our rheumatologist to get that kind of counseling, or our GP?
I think if you have an autoimmune condition and you are on immune suppression and you're under the care of a rheumatologist, I think it's a conversation to have with the rheumatologist.
And I'll clarify this question too. They want, if you get sick, if you get infected, should you reach out to your rheumatologist for care? Might depend on proximity, right?
Yeah, I think some of that, you wouldn't want to, slow down your care by any means, but I think if you are under the care of a rheumatologist who is prescribing you immune suppressive medication, obviously, if you are acutely sick and you go to the emergency room, then you should go to the emergency room if your rheumatologist has not had the chance to get back to you. But I think if a rheumatologist is giving you medicine that suppresses your immune system, and then you should be reaching out to them if you get sick, for them to guide you as to whether they think a monoclonal antibody infusion is appropriate or one of these oral medications.
So our last question is, one of our participants here has a combination of some problems, I'll just read this out with my new cataract eyes that can see one thing short and one thing, well, I don't know if I can read it. She has antiphospholipid syndrome, interstitial lung disease, lupus, scleroderma, IPH, has had some clots in her lungs and in her legs, and a stroke and a heart attack. So that there's a lot of cardiovascular involvement. Is afraid to get the COVID vaccine, has been advised maybe not to. So is there anything you could share with her to help this person feel more at ease, or what decisions are good for her?
Yeah, I understand the fear, and certainly what I say doesn't take the precedence of the providers that know her and know all her nuances. I think with the J&J vaccine, there's been concerns about, dural venous thrombo, like clots that affect a part of the brain and things like that. But I am unaware of any specific contraindication to her getting the COVID vaccine in the setting of lupus, scleroderma, pulmonary hypertension, interstitial lung disease, or even antiphospholipid syndrome. I mean, there are rare cases of patients developing low platelets after some of these vaccines. That risk is extremely low. And so I at least what just as a blanket statement, I don't see any specific contraindication to an mRNA vaccine. And I think the benefits with all those medical issues, the benefits probably outweigh the risk. I would be interested to hear what Dr. Silver and or Dr. Baker Frost would chime in.
If you guys want to add anything?
No, I think Faye answered that the way I would. You always have to discuss these issues with your primary physician, but I think and you always weigh the balance, balance the risks and the benefits. So in general, the benefits far outweigh any potential risk.
Thank you.
I agree.
Thank you. Thank you. So one last question, should scleroderma patients get their antibody levels tested to see if they are responding well to the vaccine, or is that, I don't even know if that's an easy thing to do, frankly. So I've never looked into it, but.
So there's a lot of, not necessarily controversy, but as providers, if we go based on the guidelines we've been given, the recommendation is not to necessarily check these.
Yeah.
To see if you have antibodies. One, because let's say you have antibodies, we don't exactly know what level of antibody is protective.
Yeah.
We don't know exactly how long it lasts. And if it's, if it does last, 6 months, what level would not be protective? Like, we just don't have that information. Some patients want to know, and so sometimes we will check it. I would say that I don't check it very routinely. I can count on one hand the number that I've checked. I think when patients are on things like B-cell depleting therapy with Rituxan, and they've been vaccinated, and we've tried to time it with their next infusion, and we give them the vaccine, let's say, a month before their Rituxan is due, and we want to consider them for that Evusheld if they're not protected. I have checked antibodies on those few occasions, but beyond that, we're not checking it regularly.
Yeah, and it could be may not be that useful. It may seem like it would be, but it's not really that useful. Maybe at a population level, but not at an individual level. Well, I don't believe we have any more questions, but somebody did want to make sure, they can get some of those resources on your slides. So if we're going to get your slides, and they definitely want to see the slides about mental health and well-being. I do feel like that has emerged, continually as a problem area for everybody, but the pandemic's just taken it up a notch. So thank you so much, Dr. Hant. That was so helpful.